Good day, everyone, and welcome back. In the previous session, we described normal age-related anatomical and physiological changes in the gastrointestinal tract and liver. We also explained reduced gastrointestinal motility and reduced hepatic reserve, including implications for drug metabolism. In this session, we will continue our discussion on gastrointestinal and hepatic geriatric clinical care. By the end of this session, the learner will be able to 1. Recognize atypical presentations of gastrointestinal and hepatic disease in older adults, including functional and cognitive change. 2. Identify malnutrition or impaired absorption and constipation or bowel dysfunction as clinical syndromes in geriatrics. 3. Identify gastrointestinal bleeding or anemia and apply geriatric clinical reasoning. Let's continue with how malnutrition and constipation present as geriatric syndromes. Malnutrition and impaired absorption. These are common, under-recognized, and multifactorial contributors including reduced appetite, dental disease, dysphagia, depression, social isolation, and chronic illness. Impaired absorption can worsen deficits even when intake seems adequate. Consequences include sarcopenia, frailty, impaired wound healing, immune dysfunction, and increased mortality. So, malnutrition should trigger urgent assessment and action. Constipation and bowel dysfunction are also geriatric syndromes, not minor inconveniences. Contributors include reduced gut motility, low fiber intake, medications, especially opioids and anticholinergics, and immobility. Untreated constipation can lead to fecal impaction, urinary retention, delirium, bowel obstruction, and hospitalization. Routine bowel assessment is therefore essential. Having seen how malnutrition and constipation present as geriatric syndromes, let's move on to how we can detect bleeding early and prevent gastrointestinal deterioration. Gastrointestinal bleeding in older adults is often occult and chronic rather than dramatic. Common causes include NSAIDs, anticoagulants, and gastrointestinal malignancy. Clinical presentation may be subtle, including fatigue, dizziness, falls, or worsening functional status. Early detection through vigilance and trend monitoring is essential to prevent catastrophic outcomes. One of the ways we can detect bleeding is through hepatic dysfunction. Liver disease in older adults may present subtly without overt jaundice or abdominal pain. Confusion, medication intolerance, and unexplained coagulopathy may be the earliest signs. Reduced hepatic clearance increases susceptibility to drug toxicity even at standard doses, requiring cautious prescribing and close monitoring. Let's look at medication-related gastrointestinal and hepatic injury. Older adults are particularly vulnerable to medication-induced gastrointestinal and hepatic injury. NSAIDs, paracetamol, and antibiotics are common culprits. Polypharmacy amplifies risk by increasing drug interactions and cumulative toxicity. Medication review is a critical preventive strategy in geriatric practice. Next, we'll look at functional decline as a gastrointestinal signal. Functional decline often precedes overt gastrointestinal diagnosis. Reduced appetite, weight loss, and declining mobility may be the earliest indicators of gastrointestinal or hepatic disease. Prompt assessment is required to prevent irreversible decline. Let's see the clinical reasoning. Advanced practitioners should routinely assess whether nutritional intake has changed. Consider medication effects, evaluate for malnutrition, and anticipate the consequences if deterioration progresses overnight. Before we end this session, let's quickly recap the main points. Malnutrition, constipation, and gastrointestinal, or liver disorders, in older adults often present subtly with functional decline and require early detection. Require careful assessment and medication review to prevent serious complications and deterioration. We've come to the end of this session. Thanks for watching. See you in the next session.